Yeah, it was well worth the wait, wasn't it? I call this meeting to order. Welcome to meeting number 133 of the House of Commons Standing Committee on Health. Before we begin, I would ask everyone in the room to have a look at the guidelines on this card. The measures in place are there to help prevent audio and feedback incidents and protect the health and safety of all participants, including the interpreters. Thanks for your cooperation on that. In accordance with our routine motion, I'm informing the committee that all remote participants have had the required connection tests administered. We're having a challenge with Mr. May, but it's not going to further delay the start of the meeting. I expect that we'll get along just fine. I just want you to know that that's done. Before we begin, I would like to remind members that the clause-by-clause consideration of Bill C-277, brain injury, is this Thursday. The deadline to submit amendments is in another 51 minutes. At noon today, the amendment package will be circulated as soon as possible after the deadline passes. Pursuant to Standing Order 108 Sub 2 and the motion adopted on November 8, 2023, the committee is resuming its study of the opioid epidemic and toxic drug crisis in Canada. I'd like to welcome our panel of witnesses. We have with us today Jean-Sébastien Fallu, Associate Professor at the Université de Montréal, appearing online. Masha Krupp, and she's with us in the room. She is a mother who has lost her daughter to methadone overdose and whose son has an addiction to opioids. And from the City of Toronto, Dr. Eileen Davila, the Medical Officer of Health. Thank you all for being with us today. As I expect has been explained to you, you will have up to 5 minutes for your opening statement. Et on va commencer en ligne avec Monsieur.
We will begin online with Mr. Fallu. Before we start, Mr. Chair, I would like to ask the interpreters to speak directly into the microphone. I'm about 9 out of 10 on my volume level, and it's very quiet, so I would like to ask them to perhaps speak more closely to their microphones.
Je pense que ce n'est pas nécessaire pour moi de...
I don't think I need to repeat your comments. I am certain that the interpreters have heard you and will attempt to speak directly into the microphone as you have asked. Mr. Jean-Sébastien Fallu, welcome to the committee. The floor is yours. Thank you. Mr. Chair, Vice Chairs, Members of Parliament, thank you for giving me the opportunity to testify on the study of the opioid epidemic and drug toxicity crisis in Canada, a subject I have been advocating about for 10 years. As an associate professor at the Université de Montréal for 20 years, I am also editor-in-chief for the journal Drogue, Santé et Société, and a full-time researcher at the Centre de recherche en santé publique at the Institut universitaire sur les dépendances and the Recherche et Intervention sur les substances psychoactives Québec. I also founded the Groupe de recherche et d'intervention psychosociale, GRIP, which has been operating in harm reduction in festive environments for almost 30 years. It is well known. I am also someone with lived and ongoing experience with drug use. It would have been nice to be in person with you, but I'm currently in Lisbon for 2 science events, Lisbon Addictions and the International Society of Addiction Journal meeting. Yesterday morning, I presented with Carl Hart, a world-renowned neuropharmacologist who has written several books, including his latest Drug Use for Grown-Ups, Chasing Liberty in the Land of Fear, which is an essential read. The drug overdose crisis, or rather, the drug poisoning crisis, is above all a crisis of public policy and stigma. My testimony will be primarily focused on the stigmatization of people who use drugs, as well as policies and their adverse effects. I will pay particular attention to the importance of an informed discussion and highlight the social determinants of health. The COVID-19 pandemic exacerbated the drug epidemic. The number of deaths has increased from roughly 3,700 in 2019 to more than 7,300 in 2022. Contamination, fentanyl and analogs, nitazenes, and others also play a central role in this escalation. It is crucial to understand that criminalizing and punishing people who use drugs is ineffective, stigmatizing, and aggravates the situation. Despite the complexity of the situation, one thing remains clear. Stigmatizing people who use drugs impedes their access to care and escalates the crisis. We need to refocus our analysis on the root causes of this crisis: contamination in an unregulated market due to prohibition policies, failure to prioritize the social determinants of health, and stigma and social exclusion. Stigma manifests itself in at least three forms: self-stigma, social stigma, and structural stigma. It is associated with many harmful effects, including dehumanization, shame, loss of self-esteem, distress, anxiety, depression, social isolation, increased substance use. So everything that we're seeking to counter, basically, decreased request for assistance, and discrimination in access to housing, care, and employment. These effects lead to poverty, a deterioration in mental health, incarceration, and even suicide. In short, stigma kills. Stigma is a social determinant of health. Reducing stigma is an essential goal despite ideological discourse that suggests otherwise. Reducing stigma includes using people-first language that's accurate, balanced, and unbiased, educating the public, and transforming social representations, all with the ultimate goal of transforming laws and policies around drugs. Substance use has always been an integral part of the human and animal experience. Trying to eradicate these behaviors is like opposing the very nature of human beings and animals, or trying to beat air. As a result, prohibition and criminalization not only fail to achieve their goals, but aggravate the situation by exacerbating the crisis. Moreover, our neoliberal policies contribute to misery and poverty. Prohibition policies create a toxic market that escalates the crisis, the prohibition paradox. We are far from prioritizing social determinants of health. In the face of this misery, toxic markets, and the failure to prioritize social determinants, we insist on stigmatizing, excluding, and blaming individuals, which only exacerbates the problem. For decades, our approach to substances has been stigmatizing and disconnected from reality. Rather than asking why, we continue to use the same approach and hope we'll achieve different results. Some people say that decriminalization in Oregon or BC was a failure, but that's not the case. Decriminalization is only a small part of the solution. It does not solve problems of poverty, access to housing, healthcare, social services, treatment, or access to decent jobs. In terms of solutions, several insufficient and irrelevant proposals are often put forward. However, I can see that the majority of recommendations are in line with mine, which includes rethinking drug policies in favor of an approach that is geared toward public health and human rights, promoting harm reduction services as well as access to healthcare and social services for people who use drugs, investing in all social determinants of health, including access to care and stigma reduction, decriminalizing, regulating, and legalizing drugs, implementing harm reduction policies, and finally, developing more services and decentralizing them. Thank you for your attention. I am available to answer your questions. Thank you, Dr. Fallu.
Ms. Krupp, welcome to the committee. Thank you for being with us. You have the floor.
Thank you. I want to thank you all for inviting me to speak today, for giving me the opportunity to share my lived experience with the methadone treatment and safe supply programs. I'm going to touch very lightly on one issue. My daughter, Larissa, she died in September 2020 from methadone toxicity, 12 days into her methadone treatment. I wanted to bring this to the forefront, too, because there's other ways of dying. This was at the hands of a doctor at Recovery Care here in Ottawa who did not conduct an opiate tolerance test on her prior to starting her on the methadone program, and unfortunately, 12 days into her program, she overdosed because of the dose that the doctor gave her 2 days prior. So I think it's important to know that methadone is a great tool to get a person on the path to recovery, but we also have to look at how it's dispensed and prescribed, and that the doctors prescribing this know what they're doing and not skipping any steps. But what I really want to talk about today and focus on is the protracted and lived negative experience with my son, who is in active addiction, and he's been under Dr. Charles Bro's care at the Byward Market Recovery Care location on Rideau Street since June 21, and on Safe Supply under Dr. Bro's care since the fall of 2022. He's prescribed 28 hydromorphine pills daily, in addition to his current dose of 45 milligrams of methadone. He was on methadone last year as high as 165 milligrams. He's still using street drugs. 3 years later, my son is still using fentanyl, crack cocaine, methadone, despite being with Dr. Bro and with Recovery Care for over 3 years. As soon as he was put on Safe Supply, he started diverting his Safe Supply, as most of the patients that I see coming out of this clinic on Rideau Street, I see them in front of me, coming out of Dr. Bro's office, coming out of the pharmacy, right in front of where I'm parked. I've taken pictures. They're counting out these white pills. There's a dealer's sort of come out of nowhere, and they hand them a little thing wrapped in plastic. I see them move a couple of feet, and they're smoking and injecting right on the street. This is my experience with Safe Supply, my experience with my son. I have gone in to see Dr. Bro myself personally, as is his father, over the last 2.5 years, asking for a treatment plan, asking for counseling, letting the doctor know that he's using fentanyl, that he's using crack cocaine. We're worried about overdosing. The doctor really didn't respond to anything. His answer to me was, my son is the one that has to ask for the treatment plan, not me. So the last couple of years, I have essentially been monitoring my son. I moved in with him. In fact, 3 or 4 weeks ago, I had to call 911 because he overdosed. This is all under the care of Dr. Bro, Recovery Care Clinics. We're into it 3+ years. Why am I still calling first responders when these clinics, is my understanding, under SUOP, are receiving millions of dollars in funding, 10+ million to date. Their websites purport to have a treatment plan individualized for each patient, mental health counseling for each patient. They have one mental health counselor, to my knowledge, across 4 clinics, who only is available virtually more often than not. I'm not looking at my notes anymore, but essentially, as a lived experience, and as somebody who has observed what is going on outside of the Recovery Care Clinic on Rideau Street for the last 3 years, the diversion I'm witnessing, not just my son, but the people outside the clinic, this is not working. I feel that Safe Supply has its place and can be helpful, but the dosage has to be witnessed. You can't give addicts 28 pills and say, well, here you go. They sell for $3 a pop on the streets. You've got drug dealers, I know this for a fact, through my son. I've seen it. They come to your home 24/7. You can call at 2 in the morning. They take your hydromorphine pills. They supply the crack, or the fentanyl's now down to $60 a gram. Used to be 120, 170. So addicts are like my son, who still wants to get clean. It's through the type of care that he's receiving at Recovery Care specifically, because that's my lived experience. Dr. Breaux, in my opinion, knows what's going on because I told him that I suspect my son is diverting. I want to know why he's getting so many pills. Where's the treatment plan? Where's the mental health counseling? I need to save his life. 3 years in, I should not be calling 911. They're already overextended. In closing, what I want to say is I see no evidence of all this SUEP funding, which is taxpayers' dollars, yours and mine. I see no evidence of it being spent on treatment and recovery at Recovery Care for their patients. I believe that we have to move away from what is a harmful drug legislation model to a hopeful recovery-focused model where you've got detox treatment, you've got mental health treatment, you've got assistance in acquiring housing, employment skills. I believe that safe supply can only work if it's witnessed and dispensed and there's a treatment plan attached to it. As I said, I've been trying to keep my son alive for the last 3 years. He's been in this safe supply program. I have spent hours, weeks, months, his father and I, we've been looking for a treatment program. We've been looking for something that's based on recovery. And at this point, what we see is all roads point to the Alberta model. Thank you.
Thank you, Ms. Group. Next, from the City of Toronto, Dr. Eileen De Villa, Medical Officer of Health. Welcome to the committee, Dr. De Villa. You have the floor.
Thank you very much, and good morning. I do appreciate the opportunity to appear before the committee today. As you've heard, my name is Dr. Eileen De Villa, and I'm the Medical Officer of Health for the City of Toronto. As I believe this committee is aware, I contributed to a joint brief that was presented to this committee along with colleagues from Montreal and Vancouver earlier this year, and that brief spoke to the nature of the toxic drug crisis in Canada's largest urban centres. So I'm very pleased to be here today to join you and expand on that information that was already provided, and certainly to answer any questions you may have. Before I go further into my remarks, I do want to note that as I talk about data that are related to the crisis, to the epidemic that we see today, I'd like to note that I do so with respect and with a deep, deep appreciation for what these data mean. As you've just heard from my fellow witness, we're talking about people. Right? We're talking about people who are our loved ones, our friends, our families, and our colleagues. So one of the reasons I'm here today is to share with you some stories from our clinic, where I have an incredible team of colleagues who support hundreds of clients every single day. I simply cannot overstate the heroic efforts of our frontline service delivery partners, some who work directly with me and some who work throughout the system in Toronto. They have seen the epidemic escalate over the past decade, as my fellow witness, Professor Fallu, mentioned. My colleagues have experienced immeasurable grief, as have many, throughout many communities throughout Canada. My colleagues have saved thousands of lives, and they continue to show up every day to work, despite the enormity of the loss that they've experienced and the unrelenting nature of the epidemic we are witnessing. But I do want to tell you about our clinic in the heart of downtown Toronto, operated by us at Toronto Public Health. We offer a full range of services and referrals, and we actually see a very high volume of clients every year. In fact, last year, 2023, we supported 18,575 client visits and over 21,000 client visits to our supervised consumption service at Toronto Public Health in 2022. As you know, supervised consumption service sites are clinical spaces for people to bring their own drugs to use in the presence of trained health professionals. I know this committee has heard that Canadian and international evidence and our own experience in Toronto show that these sites do save lives And yes, we do connect people to social services, and we are a pathway for many to treatment. There are currently 10 of these sites located across Toronto, operated by a range of health providers and funded by a variety of sources. And the demand and need for these services is high. Across the 10 supervised consumption sites in Toronto, there were just over 96,000 visits in 2022 and just under 95,000 visits, in 2023. And amongst these visits, staff at these services responded to almost 2,000 visits where overdoses occurred in 2022 and almost 2,300 in 2023. We saw those many visits with overdoses. And we responded to them. So in addition to providing medical interventions for overdoses, the sites also offer referrals, thousands of referrals to health and social services annually, roughly 6,500 in 2022 and almost 10,000 in 2023. So in addition to providing direct medical care, we know that the sites serve as an important entry point to a fragmented, although well-intentioned healthcare system, and we do help link individuals to further sources of care and, of course, to connection, which is an important component of that care. So when people talk about harm reduction, this is what it looks like in our clinical spaces. And these harm reduction efforts are meant to work hand in hand with connecting clients to a range of treatment options. So at Toronto Public Health, we operate the only injectable opioid agonist therapy clinic in the city. And we currently have funding to provide this treatment option to roughly 35 clients at any given time, although I can tell you that this funding is time limited. This program offers injectable hydromorphone to medically and socially complex clients who may benefit from this treatment approach, which is delivered on-site in our clinic and in an observed fashion. This particular program also includes wraparound service and supports for client-observed doses and monitoring, a coordinated referral network, case management, and overdose and prevention education. Eligibility for this program follows national clinical guidelines and focuses on those who are at greatest risk of overdose. I should note that the average length of treatment in this program is about a little over 50 days, 53 days roughly, although every client will have a different experience. That's the case when we see other health issues and health matters. There may be an average, but there is a slightly different experience depending on which person we're talking about. When it comes to this kind of treatment, we have observed and noted that some people will start and stop treatment multiple times. So that's why it's incredibly critical that we have a range of options available to meet individuals where they are in their journey. We know that when we look at our data, that we see that since opening the doors, the program has served a wide range of clients, ranging in age from 24 to 62, 73% of the clients identifying as male.
If I could get you to wrap up, Dr. Davila, you've got
Well,
some people anxious to ask you questions.
I will wrap up. Let me just tell you a little bit of a story. With respect to this
Quickly,
service,
please.
we have seen really incredible results. I was just telling my fellow witness here before the committee began about an individual client who presented to our service. She was pregnant at the time that she presented to our injectable opioid agonist therapy program. She went on to have a successful pregnancy, a healthy baby, has actually successfully completed the treatment and is now housed and has actually gained custody of her other children and is living a happy and healthy life. Lots of opportunity, I think, here. I think there are a range of issues, a range of options that need to be made available. We've heard about the importance of policy, but as well, we need strong approaches, prevention, harm reduction, and treatment that take into consideration all the conditions that optimize health and give people the best chance at reaching their full potential. Thank you very much.
Thank you. We're now going to begin with rounds of questions, starting with the Conservatives for 6 minutes. Ms. Goodridge, please.
Thank you to all the witnesses for being here today. I'm going to start out, Masha, I'm so sorry for the loss of your daughter, and you are wonderful for the support you're giving to your son in helping him find recovery. After 9 years of very marked change in addiction policy, where this Prime Minister, Justin Trudeau, has decided to flood the streets with dangerous opioids and create, Mr. Chair, thank you. Can I have my time back? The witness had his mic not on mute. Thank you. So after 9 years of marked liberal policy changes in addiction, flooding the streets with dangerous opioids, and legalizing drugs like crack and heroin in British Columbia, normalizing drug use to a whole new generation, do you believe that has played a role in making your son have a harder time finding recovery from addiction?
The safe supply, as it's administered to him the last 2.5 years, has definitely played a role, because he's the word is diverting. Let's use the real word. It's called trafficking. I've had the police over to talk to him about what he's doing. He fears law enforcement enough that not wanting to go to jail. He doesn't have a criminal record. But yes, in my view and my lived experience, the safe supply in my son's case, because there's no treatment attached to it, it's just the doctor gives him all these pills, he diverts them, gets the drugs he needs, and he's still an addict. In my view, if he didn't have these pills and was receiving methadone, or if he was receiving his hydromorph under witness dosage and there was a treatment plan attached to it, I believe it would be successful. As it stands now, to me, it's not successful. It needs to be overhauled. There has to be regulatory oversight. You're flooding the market using taxpayers' dollars with lethal opiates that are making their way into high schools, adolescents paying up to $10 a pill for a hydromorphine. So how could this be helping us?
Well, I think that actually leads into my next question. Do you think that the government calling this safe supply and using that term and making it seem like these are somehow safe is a responsible word?
It's an unsafe supply, in my view, as a mother with a lived experience, observing how recovery care dispenses their safe supply. It's not safe. It's only safe if it's witnessed, or as the doctor here was in their clinic, where it's a witnessed or injectable dosage, then I'm all for it. But you need oversight. You need to be audited. You can't dispense these kind of drugs to addicts and expect them to take them as they're prescribed. Like, come on.
Well, and it's interesting. Do you believe that the government has effectively become the drug dealer in cases like your son's?
Well, let's see. The doctor's dispensing the hydromorphine pills by legislation. Federal government legislated. So you've got the federal government, you've got the doctors involved, you've got the pharmacies, and then you've got the street drug dealers. So I would have to say that at a higher level, yes, our Liberal government right now is acting like a drug lord, maybe. You know, here's your hydromorphine, the doctor gives it here, here's my son, and there's the street dealers. It's a chain, so yes.
It is terribly concerning. One of the things you said in your opening statement, you talked about how your son goes to this recovery clinic. You have to take him every single week, but all he gets is a script. He doesn't actually, and he does a drug test. He doesn't actually get any counseling. I went onto the Recovery Care website, and they talk about mental health. They seem to talk about the fact that this exists, but you're saying that in the 2 years your son has been part of this program, he hasn't received mental health support. Is that correct?
No, the only thing when I have faxed in letters to Dr. Bro, or the few times my son allowed me to go in to talk to him, my son comes home with a sheaf of photocopied anything anybody could access, Narcotics Anonymous, mental health crisis line, suicide line. It's almost an affront to me as a taxpayer and a mother of an addict, because I know they're getting this funding. Are you telling me that with your $10 million plus you can't have an extra counselor in your clinic on site? None of the things that they claim in their website, in my experience, over 3 years, have ever been realized with my
Has
son.
he actually received, to your knowledge, counseling from a counselor at Recovery Care Clinic?
No.
Has he ever received virtual counseling from a counselor associated with Recovery Care Clinic, to your knowledge?
I think once. The counselor's name is Jimmy. My daughter had the same one, even though she was at a different Recovery Care Clinic location. Jimmy was the counselor across all 4 clinics, and because this was COVID, initially with COVID, it was all virtual. So my son, when he did agree early on into the program, before the Safe Supply kicked in, early on into the program, he agreed to speak to, because as his parents, we were giving him ultimatums. If you don't get counseling, we're going to have to, we're trying to leverage, some sort of consequences. He spoke to Jimmy once. The second appointment, Jimmy dropped it, and the third appointment, my son dropped it, and that was it.
That's incredibly troubling. Thank you so much for sharing. My next question is to Dr. Davila, really quickly. You say that they are witnessed in the city of Toronto. Is that what you were pushing for? Was all witnessed in? Is that why you moved towards trying to get Toronto to have decriminalization and a legalization of drugs like crack, to have more witnessed programs, or was this to just have a free-for-all?
So, through the chair, what we're trying to do is provide, evidence-informed advice around how to address a very, very challenging situation on the ground.
So witnessed, yes or no?
So we offer a clinic service that is witnessed, but I recognize that there are a range of different options that are required to meet the different needs of different people.
Thank you, Dr. Davila. Thank you, Ms. Goodridge. Next, Madame Brière, for 6 minutes, s'il vous plaît.
Ms. Bruyère for 6 minutes. Thank you to all the witnesses.
Your story with us. Docteur Davila, vous entendez les questions de...
Dr. Davila, you've heard the questions from the Conservatives and the response from Ms. Krupp. In what circumstances should we allow for unwitnessed dosing? And are there any occasions where they should be excluded?
So, through the chair, I thank you for your question. I think each individual patient, as is the case in any medical encounter, actually rests with an assessment of what the individual's needs are and how best to meet them. I will be very upfront with the committee. I'm a public health physician, so I actually am not actively engaged in individual patient care. But from my training, when I did do individual care, it is incredibly important to actually understand what is the unique diagnosis for the person in front of you, what are the circumstances in which they live, and how then do you provide the best evidence-informed treatment intervention, recognizing, what's the best, medical treatment, and how do you make that medical treatment as successful as possible given the unique living circumstances of that person. We know that whether you're treating high blood pressure or diabetes, each person will require a slightly adjusted version of the treatment. There are general guidelines, but how to apply those guidelines depends on that individual and what actually makes sense.
Thank you. Dr. Fallu, merci de participer.
Dr. Fallu, thank you for being a part of this meeting, even though you are currently abroad. And you've heard the questions and the answers so far. My question is quite simple. What do you think of them?
English this time. First of all, I'm also deeply saddened by any death because of many factors involved, but drug deaths. But I really think I asked the chair and the members of the committee, let's stop politicizing this debate. I said in my testimony, we need a fact-based debate. Policies have not changed that much. There's no major policy change in the last year. We're still under criminalization and prohibition, and we're still stigmatizing people, which prohibits them to access treatment. We're not flooding streets with drugs. Prohibition is flooding streets with drugs. Of course, there may be diversion, but that's just a tiny part of the major problems we're facing for decades of prohibition that brought this toxic supply. That's the fact, and experts agree on that. If we don't change our way of thinking, we're just going to continue this crisis and deaths. People are dying. And when I hear we should adopt a recovery model, I'm sorry, but we are already in a recovery model for decades. That's where the money is, way more than in prevention or harm reduction. And there's a little tiny change in the last years that was deeply needed to add other tools to a continuum, a spectrum of services to answer different needs and walks of lives. The Alberta model, and this is a false dilemma. It's a sophism. It's not either prevention or harm reduction or treatment. We need all of those things. We need everything. And nobody I know, a serious person, will defend harm reduction, will not be in agreement with recovery. And in fact, and my colleague testimony, Davila told you, harm reduction accelerates access to treatment, to recovery, because it's a first contact for people. And so even the Alberta model, I'm sorry, but we just learned that they're under declaring deaths. So Alberta recovery model is not a model to follow. Having more recovery, of course, but we need to change our way to address this problem. That's what I think of that.
Est-ce que vous avez... Merci d'ailleurs pour...
Thank you for your answer. Do you have a solution, a proposal, or any recommendations?
Les solutions puis les
Well, I did share a few in my opening remarks, but as I said, we won't be able to solve such a problematic issue without doing many different things. We need to invest. We're talking about a housing crisis. We're talking about access to health care. We have great care in Canada, but it's hard to access it. There are policies that stigmatize and create a toxic market. With opium, heroin, fentanyl, every time these things are banned, there are more dangerous drugs that show up on the streets. We are responsible for this toxic crisis because of our policies. We need to realize that substance use is part of the human nature. It's never going to go away. And so we need to find a way to frame the market, because the market will always exist. Either we leave it to organized crime or to multinationals, or the government should be responsible for it. There are risks. There will never be a perfect policy. And there will be disadvantages, but we need to find the best one. And we can't go back to prohibition. Thank you. Thank you, Dr. Fallu. Mr. Thériault, you have 6 minutes, please. Thank you very much, Professor Fallu. Ms. Bruyère had asked some of the questions that I wanted to ask you, but I'll try to go into more specifics. When you're talking about structural stigmatization, can you give us more details on what you were talking about? Structural stigmatization is something that is caused by policies, legislation, whether it be in acts or in organizations. But at the heart of everything, it's in fact the legislation, and we are labeling individuals as abnormal and immoral. And if we have legislation that punishes and bans, well, that automatically stigmatizes people. And during my presentation yesterday, I stated that it's more important to reduce the stigma with drug use than the use itself. We heard people and ideologists like Mr. Humphrey, who wrote an article in The Atlantic. There are a lot of false arguments out there, but structural stigma is caused by our legislation. And by banning normal human behavior, well, we exclude people and we kill them. As I said, stigma has so many negative impacts, and it leads to people dying. Earlier, you mentioned that Alberta was not sharing accurate numbers. I would like to know how you heard that. I can find the reference for you. It's an independent assessor, and this was published 2 days ago. I could definitely send that to you. Yes, if you could send that to the committee, that would be very useful for our final report. You talked about decriminalizing, framing the use of drugs, and there's a polarization of the debate here. Oregon and BC changed the way of doing things. Alberta is saying that detox, involuntary detox, is the way to go. What didn't work in Oregon? And what didn't work in BC? Why are you saying that it's not a failure? And under what conditions could it have worked? There are a lot of elements to your question, and I'll try to be brief. If we only decriminalize, as was done in certain states and provinces, without solving the issue of access to care and treatment, improving access to housing and good jobs, and anything pertaining to social determinants of health, nothing's going to help. It just removes having a criminal record, maybe destigmatizing a little bit, but it's not enough. It's a half measure. It's not going to help reach our goals, and we'll see it as a failure and we'll take a step back. Decriminalization is not going to solve the issues of capitalism and poverty and people who are unhoused and who have mental health issues. We need broader policies for that. We need to go much further and frame that market. But that's only one tool in the toolbox. Mandatory treatment, and I would also like to say that experts say that the number of deaths or people who have issues is similar whether drugs were decriminalized or not. So why bother infringe upon human rights and criminalize people if there's no impact? For mandatory treatment, the data is limited, as always. Some experts say that it's about as effective as voluntary treatment. I've seen that it is not as beneficial, but we don't talk about deaths, and we don't talk about how people who have addiction issues have mental health problems. And how do we decide when to impose such a treatment? Because we need to look at the root causes of addiction, and we need to look at the social determinants of health, trauma, access to care, instead of putting in place a mandatory treatment. And I'll end on this. We need to start by making this treatment voluntary and accessible before making it mandatory, because it's not accessible. Why? Because it's stigmatized. So it's not something that is prioritized by politicians in public resources. Thank you, Dr. Fallu. Mr. Johns.
Let's please.
Thank you, Mr. Chair. First, Ms. Krupp, I want to acknowledge also sending my condolences to you for the loss of your daughter, and also I want to thank you for and commend you for your courage in supporting your son and your advocacy. It's all of our job to help support your son, and that's the goal of this committee and this study, is to provide recommendations to keep him alive and a pathway to a better life. Now, you talked about drug replacement therapy having its place. Can you speak about the place that you would like to see it play?
You mean the safe supply,
Yes.
how the hydromorphine is being dispensed?
Yes.
Well, I would like to, from my lived experience, I mean, I'm hearing all these answers to questions and long-winded, and, you know, I can appreciate it, but I want to know how many people in here, in this committee and live, have lived what I have lived through. You can talk about references. I point to the Alberta model only because we're desperate as parents to find something that will save his life. They're monitored. We need something monitored. We can't be dispensing drugs that are making their way to the streets. It's a currency for drug addicts and people like my son. This hydromorphine is a currency unless it's strictly regulated, perhaps in a pharmacy setting, perhaps in a setting like the doctor here talked about, but it cannot be given to them 28 pills at a time every day for them to go and trade them for street drugs. You're defeating the purpose of safe supply.
Do you feel that the provincial government in Ontario is doing enough to support people struggling, the Conservative government there, in this toxic drug crisis that we're facing right now?
I don't know very much about what's going on in Ontario. I've been more focused on Ottawa, but from what I've learned today from Dr. Davila, I would have to say the clinics that she's talking about, I mean, I would look at bringing my son there because it's witness dosage. Maybe that'll help. I want to get him away from where he can sell. The only other option I have is call the police and put him in jail. And that's not an option. I want to get him away from where he is not diverting his safe supply. Plus all the other patients I see. These people are homeless and marginalized, but they deserve treatment. Not selling their stuff and walking around in a daze and collapsing on the sidewalk. 12 blocks from here. Any of you members could go down and walk and see what I see every Friday.
Yeah.
Something has to be done, and I'm not sure which, I don't want to politicize it either, but what I'm hearing today gives me a bit of hope from Dr. Davila. I'm talking with what I've seen, some change, something has to be done. You're just producing more addicts. You're introducing hydromorphine into the high schools. That's a fact. And if everybody's okay with that, then let's not politicize it. Let's just pretend everything's A-okay.
Well, thank you again for your courage in fighting for your son. Now, Dr. Davila, earlier this year, the federal government rejected Toronto's application to decriminalize drug possession for personal use within the city's borders. Now, both the federal government and the provincial government in Ontario say that this is a health issue, not a criminal issue. And now the Minister of Mental Health and Addictions said in a statement that the city's request didn't adequately protect public health and public safety. And we know this has been a debate in British Columbia where law enforcement has said they need more tools. But law enforcement, the chief coroner of British Columbia and the chief medical health officer still support decriminalization. Do you believe decriminalization is an important tool in the response to the toxic drug crisis? And do you think the request could have been modified to address concerns about public safety like was done in British Columbia? And if so, how?
So through the chair, thank you for your question. I do, as does Professor Fallu, believe that the answer, the solution for us lies in a broad range of interventions. I think we need everything. More prevention, more harm reduction, more treatment, and yes, I think we need better drug policy. The evidence actually shows that this makes a difference and that criminalizing people for drug use is actually not successful. It wasn't successful with alcohol. It will not be successful for other drugs. I think that's the short version of the story. I regret that, our application was not seen as supportive enough of, and you use the words community and public safety. I assure you that while, of course, our application was made with people who use drugs in mind and protecting their health as much as possible, that it's also about the rest of the community, right? I'm a public health physician. My job is actually about the population's health, and that includes everybody. And that application was developed with a broad range of stakeholders, with public consultation, and yes, with the involvement of law enforcement, although we were recognizing that at the end of the day, and we still argue, as does the evidence, that when we're talking about substance use, it should be appropriately treated as a health issue. But certainly policy does make a difference. The environment within which we're operating makes a difference. And as Professor Fallu has said on a number of occasions in front of this committee today, we absolutely need to think about the broader social determinants of health. Substance use and substance use challenges do not occur in a vacuum.
Thank you, Dr.
You confirm
Davila.
the
Thank
place
you,
we're on
Mr.
board?
Johns. And next, Mr. Majumdar, please, for 5 minutes.
No.
Jordy.
Mr. Doherty, please, for 5 minutes.
Throwing your weight around today, I see his chair.
You gave me the list.
Okay. To our witnesses, thank you for being here today. To Mrs. Krupp, our family does have lived experience. My brother lives on the street and has been on the street for years, struggling with his addiction. I lost my brother-in-law to an overdose, also an uncle as well. So I really, truly appreciate your testimony today. Dr. Davila, is it your position today the same as in 2018 when your office released a report in which you recommended the legalization of highly addictive and deadly drugs such as heroin, meth, and cocaine and fentanyl? Do you believe that that is still your position today?
Chair, my position is that we need to take an evidence-informed approach to substance use,
Okay.
and that the current criminalization of those who use drugs is actually not serving
Okay.
our shared objective
So
of a better,
legalization of those?
healthier society.
So you agree that we should be legalizing heroin, meth, cocaine, and fentanyl?
I think we should be treating substance use as a health issue,
Okay.
and we need to modernize our existing policy approach to
Okay,
substance
now you're a
use.
public health physician, is that correct? You're not actively involved in these centers. You're a public health physician that drafts policy, is that correct?
So I do not provide direct clinical treatment.
Okay, thank you. Dr. Fallu, I appreciate your testimony today. You called decriminalization in BC a success. Were you aware that the leading cause of death for children aged 10 to 18 is overdose?
Yes, I am. But
Is that
I-
a success to you?
Do you want me to answer?
Well, yes, please.
Okay. I'm a scientist. And I know that causal attribution is really complex, and you cannot, because something is higher than before decrim, attribute this to decrim. There had been other factors at play.
Okay.
Inflation, housing problems.
I appreciate your answer. Thank you.
It was a success. Okay.
I appreciate your answer. 47,000 Canadians have lost their lives since 2016. I struggle to see how that is a success in Canada overall. I'll go to Mrs. Krupp again. Your comment regarding safe supply. We heard from the parents of Brianna McDonald a couple weeks ago. That was a 13-year-old that died by overdose alone and in a homeless encampment. Their powerful testimony include the following quote: "The words safe and drugs don't belong in the same sentence." Would you agree with that?
I would most definitely agree with that.
How old was your daughter when she died?
My daughter was 46.
How old is your son today?
He's 30.
Do you believe that the federal government has fooled people into believing opioids and other drugs are safe based on marketing of harm reduction programs?
I believe that there needs to be an education for sure. I mean, I had to educate myself on safe supply, methadone, like things like methadone has a half-life, the recommended doses when you're starting a program. In my daughter's case, the doctor started her off on 30. And yet the literature I reviewed across Canada and the States, including all the medical associations, recommend 10 to 20 dosage. He started her at 30, didn't do an opiate tolerance test. There's all kinds of things that parents need to be aware of. And in terms of Brianna, the tragedy there is beyond me. A 13-year-old, the fact that the parents couldn't get her the help that they desperately tried to. Their hands are tied by policies, by legislation, by the ignorance of the general. You have to be living it daily. Like, let me tell you how I spent my Sunday.
Just one sec. I just want to get this online. Have you witnessed safe supply being diverted into the hands of children?
Not children, adolescents.
Teens?
Teens, once, downtown.
Downtown.
They knocked on our car window. My son had just gotten in from his Friday visit, and the boy looked to be about 19. Tapped on the window. I said to my son, lower it, and he asked for hydromorphine, begged for 2 pills. He said, I'll give you $20. And, I said, I'm really sorry, you can go to the clinic, and we drove off. Okay. That's right, just blocks away from here.
Thank you.
Thank you, Ms. Group. Thank you, Mr. Doherty. Dr. Pawlowski, please, for 5 minutes.
Interestingly, I think we see perhaps a little bit of convergence of opinion. I'm not a fan of safe supply for reasons that can I call you Mrs. Krupp? Masha. For reasons Masha has talked about, concerns over diversion, and for a lot of people on harder stuff, the oral dilaudid doesn't cut it anyhow. They go on to use harder stuff. I'm also, for the record, not a big fan of decriminalization. I think the police need to have the legal means in order to control people who are publicly using publicly selling drugs. Now, what you have said, though, Masha, is that you think it's a totally different thing when you're actually witnessing safe supply, where someone gets the drugs there, they don't bring it home to possibly sell it. And that is certainly what Dr. Davila has talked about in this one clinic. And when we've heard a lot about the evidence of safe supply, in fact, my reading of the literature, a lot of the evidence comes from places like Europe, where they've done a lot of heroin-assisted treatment, which is exactly that, witnessed treatment, and this is a Swiss model, where people can come in 2 to 3 times per day and get a witnessed dose of intravenous drugs. For the most part, they don't go home with drugs. Someone described our safe supply and getting a whole bunch of Dilaudid as the poor man's version of that, because it's more expensive to have a witnessed program. Now, you I think have already said, but again, for the record, if you had the option of bringing your son to the clinic that Toronto Public Health has, where he would get witnessed doses of intravenous medications, would you think that would be better than the treatment you currently receive?
I certainly think what you're, yes, I would, and I think I mentioned that to you before it started. If I could take him to a clinic here in Ottawa where he would get an injection, whether it's 2 or 3 times a day, most definitely. And I also wanted to just clarify, I'm not in support of decriminalizing these this is just another path. I'm not in support of that either. The police do need to have a means of, I have seen the proliferation on Rideau Street and in the market of all these people, because there's a safe injection site right next to Recovery Care. It's not working. You cannot normalize drug use. I was there on Friday, and I had to go to the drugstore to get something, and I'm not a fearless person, a fearful person, I mean. And there's this, I get to know all these people that are diverting and using right in front of the clinic, in front of all the tourists, parents walking by with kids. This guy, he's always got a big stick, and he's higher than a kite. You can see that. And he's twirling it, and sometimes he gets angry. So, you know, I'm gauging the situation. Well, do I walk around him? Do I wait? Do I go somewhere? Why am I supposed to be dealing with this? Is this safe supply? Is this what decriminalization will do? Safe injection, I support. But why are they doing everything out in the open if safe injection and safe supply is working?
Now, Dr. Davila, that clinic that you have, which actually provides intravenous Dilaudid, my understanding is you only have 35 patients on that. I know the Swiss model with heroin-assisted treatment, they put thousands of people, and these are hardcore drug users. These are not teenage kids. These are not people who've been using it for a few months and maybe spiraling down. These are people who've been using it for years, of often people who've repeatedly gone to jail, and they kind of accept it, and they'd failed everything else. And they put them on, and literally thousands of them. You have 35 in Toronto. Should we be considering expanding that access to the clinic? So, for example, Masha's son, there was the availability of that with the real hardcore cases. You can't get them off anything else. Should we be opening more clinics like the one you have? And then I think you told me you were actually going to lose the funding for that clinic.
So through the chair, very briefly, yes, of course, we should be expanding treatment options like the one we have in Toronto and many other treatment options. We should also be expanding prevention options. We should be expanding harm reduction options, and we should be modernizing our existing drug policy. The notion of decriminalization as a policy support to more access to better services and real access to services, plus addressing the social conditions within which these health challenges take place. The notion here is not to endorse widespread unregulated use, but as Professor Fallu says, the reality is that this is human behavior. It's incredibly complex, and it requires a nuanced and complex discussion and nuanced, complex solutions. To think that one simple change or one avenue or one approach will actually change this is just not reasonable, and in fact, it's not evidence-informed. So, we're putting in front of you, and what I've sought to do across the board, whether it's to decision makers here at the federal level, at the provincial level, and certainly at the local level, is to put in front of you the best available evidence on the challenges that we see that are impacting on the health of our citizens.
Thank you, Dr. Davila. Thank you. Ensuite, Monsieur Thériault, pour 2 minutes et demie, s'il vous plaît.
Mr. Thériault for 2.5 minutes, please. Thank you, Mr. Chair. 2.5 minutes is quite short, so I'll be quick. Professor Fallu, I hear that you're not alone, and I've also heard that prohibition, criminalization leads to stigmatization. Stigmatization keeps us from improving the lives of people with addiction issues. And so decriminalization, and for example, if somebody had a criminal record, they would lose their job. And so we've talked about police agencies, and they agree with that process. This is something that we've done in Quebec. It's something that was being done in Portugal, where I am as well. It's been in place for 25 years. And it is a step in the right direction. But it's not true to say that decriminalization does not allow police to intervene. We need to have a clear debate. Police act in Portugal and in Canada for cannabis even. It's false to say that decriminalization stops police from being able to act. But decriminalization is a gray area. It is a first step, but there are things that cannot be solved by decriminalization alone. And I would like to rectify, as Mr. Doherty put words in my mouth. I did not say that decriminalization in BC was successful. It's a policy that is better than prohibition. It's not enough, though. It does not solve all the issues, but it has solved some. Thank you, Dr. Fallu. Mr. Johns.
For 2.5 minutes.
Well, thank you, Mr. Chair, and I'll follow up on that. We know that Alaska saw a 45% increase in toxic drug deaths last year alone. And their death rate is now higher than British Columbia's. In fact, Lethbridge is triple that of British Columbia, where they close safe consumption sites. Regina, where they don't have a safe consumption site, is 50% higher, actually more than that than British Columbia, their death rate. Baltimore, 400% more than British Columbia. Tennessee, West Virginia, all higher. They don't have safe supply. They don't have decrim. So, Professor Fallu, when you hear politicians blaming safe supply as flooding our streets or decriminalization as the driver of the death rate, maybe you can comment on that. Then I will say that in British Columbia, the death rate went from 7.9 per 100,000 to 30.3 under the Christy Clark John Rustad government in the 3 years prior to the NDP government. And they actually went from 30.3 to 46 under the BC NDP, but came back down to 41 since decrim. Maybe you can speak about that, because that provincial government didn't have safe supply and they didn't have decrim.
Yeah, well, safer supply, because I don't say safe supply, and I think it's quite not fair to talk and continue to talk about safe supply. I hear more conservatives, if I may politicize a little, or anti-harm reduction or safer supply advocates use the word safe supply. We say safer because it's safer than unregulated and uncontrolled substances that are on the market. That's what prohibition is. Prohibition is refraining to have some rules and quality controls, and it stigmatizes people. So safer supply is an attempt to do something because of this problem, which basically is the very core of deaths. If people die of overdose, it's because they don't know what they're taking. I took fentanyl in a hospital setting. I knew what it was. It was under medical supervision. Fentanyl is not a dangerous drug. The danger is not to know what you're taking. Let's say you go to a liquor store and you buy alcohol and you don't know what's in it. Either it's 5% alcohol or 95. How can you have a responsible use? It's impossible. So the thing is, safer supply, sorry, is a way to have a plaster, a Band-Aid solution on something that's very more profound, which is the absence of control in a context where people use and will continue to use. So we have to find nuanced solution, as my colleague Davila said. So safer supply maybe it's new and we need to continue evaluations. But what we know up until now, it has better, positive, more. The balance is on the side of positive effects.
Thank you. Thank you, Dr. Fallu. Next, Mr. Moore, please, for 5 minutes.
Thank you, Mr. Chair. Ms. Krupp, the term safe supply or safer supply, as the previous speaker said, conservatives didn't invent that term, but it is through the listening to those with lived experience like yourself that we're seeing the evidence of this approach being anything but safe. So when I hear your description of your son's experience and your experience, nothing about it sounds safe. Nothing about it sounds safer. You referred to his so-called safe supply as a currency, and about the now prevalence in high school, the diversion and the lack of traceability on this so-called safe or safer supply. So can you comment a bit on that? Because one of your, in your opening remarks, you mentioned that your son is still using crack cocaine, fentanyl, so is still using these hard drugs while diverting his safer supply. So what about this, in your opinion, is safe?
Well, again, I'm going to just point to my experience, lived experience with my son. I don't see anything safe about it. How could it be called safe supply when 3+ years later, he's still going to the clinic, he's still seeing the same doctor, all he's dropped is his methadone, and he's done that himself, when I think his methadone never should have been dropped, because the methadone has to be, according to what I've read, you can't drop the methadone if they're into fentanyl still. So all that to say, 3+ years later, he's getting his methadone, he's getting his Dilaudid. The Dilaudid is a means of currency for him to continue using crack cocaine. So it's not safe because he's still using unsafe street drugs. That right there, the whole purpose of the Safer Supply program was to divert addicts from using harmful street drugs. Well, that's not happening in my experience. Not only is he continuing to use harmful street drugs, the safe supply that he's being administered every day by a doctor is making its way where it should not be, which is in the skate parks. My son was a skateboarder. Skate parks, adolescents, and they have money to buy these pure hydromorphins. So I cannot call this safe. Otherwise, my son's results would be different. We're not talking about a month or 30 days. We're talking about 3.5 years. So there's your experiment of our lived experience of safer supply. Take it for, and it's certainly evidence-based. It's certainly fact-based.
Thank you. Professor Fallu made the remark that nothing has changed in the last decade. In fact, there's been tremendous changes in law. I'm thinking specifically about the current Liberal government's Bill C-5, which now allows those that are importing, exporting, and producing, such as in a meth lab, Schedule I, the most serious drugs, to not serve any time in prison, but to have house arrest, which puts them back into the community. Your evidence about your son being able to obtain these drugs, what message do you think it sends to young people if there's no consequence for someone who's running a meth lab or importing cocaine into our country, and all the while, as you described it, the federal government is handing out this so-called safe supply.
Well, I wasn't aware of the finer points of C5, so thank you for that. I'm going to educate myself on that. There have been changes. In fact, methadone was I want to bring that because I know the doctor said methadone was highly, highly regulated by Health Canada up until I think 2015 or 2016. So in terms of these, why all of a sudden can everybody dispense methadone at any clinic? The one, clinic, a doctor killed my daughter who wasn't trained to dispense methadone. That's a fact. In terms of house arrest, that's the most ridiculous thing I have ever heard. In other words, you can come and produce crack and whatever. You can be a liberal and a progressive country, but you cannot. Hard drug use is not normal. It shouldn't be encouraged to be normal. It should be treated, and it should be pointed to recovery. My son doesn't want to be a drug addict. He doesn't want to use methadone or crack or fentanyl. He wants to be normal, but he's an addict. And we have tried to get him the help. And yes, it is very nuanced, as the doctor has said. I think overall, first of all, if you're producing drugs and selling them on the street, you go to jail. That sends a message. Or maybe perhaps people have to start a vigilante thing and we'll take care of the drug dealers as parents.
Well, unfortunately...
Thank you, Mr. Moore. Thank you, Ms.
Out
Group.
of time, Mr.
Yep,
Chair?
you're out of time. Next, Ms. Kayabaga, please, for 5 minutes.
Thank you, Chair. I also would like to extend my condolences to Mrs. Marsha. I can call you Marsha if that's okay. And thank you so much for all of you for being here. My questions are going to go to Mr. Falloux. Bonjour, Monsieur Falloux. Earlier, someone mentioned something around the Alberta model. And I just wanted to ask you, I kind of looked it up a little bit because I think I've heard about it, but I was like, let me dig in a little bit when you mentioned it. The Premier of Alberta said that the Alberta model is working, right? And yet we're seeing that the opioid crisis has contributed over to nearly 90% of the deaths in Alberta. What are your comments around the Alberta model, and what can we learn from the actual facts? Mr. Falloux, ça c'est pour vous.
Yes, thanks. First of all, once again, I want to say that we have to have a fact-based debate. I never said, as MP Moore said, that nothing has changed. I said with tiny, small changes. So please, let's talk about reality here. And by the way, I said I'm a person with living experience of drug use, and I'm a normal person. I'm not addicted. I've been using since I'm 15 years old. I have to rectify that. And everybody here probably uses alcohol and are normal too. Our alcohol is a hard drug. The recovery model. Recovery is very important. But since addiction or substance use disease is one of the most difficult human behavior to change. We used to call that a chronic health disease. So even recovery after 3 years, the success is really tiny. We have to put the burden on the evidence of recovery too. It's very difficult to help people to stop using. We're into helping people to live better lives, reduce use, but people have relapse episodes and they go back, and sometimes it's a long life to get better. Sometimes it's easier, but it's faster. But overall, recovery is really important. We need all the tools. It may be effective in some cases, especially when people are ready and have other factors helping for that, but just having only recovery as a strategy will kill people.
Thank you. I do want to put on the record that not everybody uses. It's very important to note because that would be misleading to say that everybody in this room or around our country uses. It's not true. I have a question around the fact that you're very open about your journey of drug use, and you're a professor, and obviously there's a lot of young people who listen to you talk about prevention at the same time as being very open about your journey of drug use. How do you manage to be relevant on the drug prevention and be so open without glorifying it? Because this is something that has plagued many communities and affected many families.
Very good question. First of all, you're right. It's not everybody. It's almost everybody when we include also medications in a lifetime. It's really rare that nobody uses neither alcohol, coffee, tobacco, medications, but it's not everyone. Yeah, I've reflected on that. And I don't have all the time I need here to explain my journey, but it's certainly not to glorify drug. It's really to destigmatize and change the representations, because all we see is completely distorted from reality, because there's a lot of people using, even active people in our society contributing, taxpayers, judges, police officers, lawyers, journalists, and politicians that use drugs. So until we just speak the truth, we will be very bad at doing what we need to do and addressing this complex reality. As Dr. Davila said, it's a complex thing. We need complex solution and a nuanced discussion. I don't want to say neither, and that maybe is the problem around these debates. We're not nuanced. It's either good or bad. We need to be nuanced. It's not to glorify drug use.
I'm going to pivot my question.
Oh, sorry, that's your
more time.
Ms.
Okay.
Kayabaga. Yep. Next, Ms. Goodrich, please, for 5 minutes.
Dr. Ellis.
Dr. Ellis, please.
Thanks very much, Chair, and thanks everybody for being here. Just a couple of comments, if I might. First of all, Mr. Fallu talked about depoliticizing this situation. I would draw everybody's attention to a social media post in May talking that, as it says here, hey everyone, at Pierre Poilievre is a hashtag public danger. He is way more toxic for society than all drugs. That doesn't sound like depoliticizing this incredibly important debate to me. That being said, Mrs. Krupp, thank you very much for your testimony. I had a chance to read it, and I really appreciate you being here, and apologize for not being able to be here right away. We talked a little bit about methadone and, of course, the tragedy that happened in your family related to methadone. And I once was a family physician and had a license to prescribe methadone, and at that time it was necessary to prove the competence as a prescriber before you were allowed to prescribe methadone. In my reading, those regulations changed in 2017. And in your mind, if that regulation continued to exist, would that have changed the outcome in your family if you had a competent prescriber?
If those regulations were in place, I believe most certainly my daughter would have been alive, because the physicians that were dispensing prior to 2017 had to be trained. Now they are not. For example, Recovery Care has 4 clinics across Ottawa. Guess how many doctors have the certificate for addictions? 1, Dr. Charles Burrow. All the other doctors at all the other locations, including the one that my daughter went to, none of them have addictions training.
Those comments, of course, are very, very concerning, and I think it's something that this committee needs to take into consideration as we draft recommendations around how things need to change in the future. And Dr. Davila, I found it interesting. I had a chance to read some of the comments that you've made. Am I right on behalf of Canadians in saying that when you talk about legalization and some of the proposals you put forward, that you didn't believe there would even be an age limit on use of unregulated drugs in this country? Is that true?
So let's be clear. What I have put forward and what we put forward at Toronto Public Health is in respect of decriminalization and a nuanced discussion on how to create drug policy that actually better supports health.
Yeah,
That
I guess
has to be a
that
part.
wasn't my question. My question was very specific, does your policy include the fact that there be no age limit?
So our decriminalization application did include young people who we recognize are actually also very much
Sorry,
suffering
again,
from
I'm going to
addiction.
interrupt you, but you're giving us a word salad. On behalf of Canadians, your legalization program did not have any age limit whatsoever.
Through the chair, it was a decriminalization application to the federal government, and yes, it considered young people who are also suffering with
So,
challenges of substance use
I guess,
in order to
Dr.
protect
Davila,
their
I am
health.
going to interrupt you there because you continue to say your same line over and over again, and I understand why you're doing that. I assume it's because you're embarrassed to come out and say what the actual truth is, that on behalf of Canadians out there, of course, those of us on this side of the House do realize that young people suffer with opioid use disorder. Of course we do. But in the policies that we've read that you've put forward, you're talking about legalization, which you want to argue and call by a different name, but also not admit the fact that it includes no age limit for young people.
So through the chair, it was an application to the federal government for decriminalization. Yes, it considered young people because they are actually suffering and stigmatized related to their drug use. And as well, you'll note that our strategy at the City of Toronto does consider a very broad range of approaches. We recognize that it is not a simple solution that will actually get us where we, I believe, want to get to, which is a healthier, thriving community.
Yeah,
We
I
actually
thank
need
you-
better
I
drug
thank you for that,
policy,
Dr.
we need
Davila, but
more
what I would
prevention,
suggest
we
to
need
you-
more harm reduction,
excuse me.
and we
please.
need more
Excuse me,
treatment.
ma'am, but yeah,
Go
these are
ahead,
my
your last
questions.
question, sir.
Thank you very much. Appreciate that, Chair. What we're seeing here is the fact of the matter that neither of Mrs. Krupp's children were born wanting to be addicted to drugs. Everybody over here realizes that. But I think, Dr. Davila, what you're failing to realize, and of course why your proposal was actually shot down by the province, is the fact that nobody in this country now believes that legalization of drugs and giving out drugs for free especially to kids, is in any way, shape, or form going to change the narrative of the chaos and drugs and disruption that policies such as yours are allowing to happen on the streets. And I guess, the fact
Mr.
of the
Chair?
matter is...
Dr. Ellis, that's your time, if you
So
want.
If I may,
Through the chair,
just
if I
Chair,
may
just to
address-
finish
Mr. Chair?
up, if
Yeah,
I hope you're happy
Okay, we have a point
of
of
the 10
order from
cities
Ms.
that now
Briere.
exist.
So-
Point of order,
Point of order,
excuse
go
me.
ahead.
We are not talking about legalization, we
Yeah,
are talking about
Yeah,
decriminalization.
thank you, Ms. Briere. Okay, Dr. Ellis, are you finished?
Sorry,
I don't think there's
Your
anything
time
else
is
to
up.
say, but thank you, Chair. I appreciate you.
Okay.
I'm not finished, but yes, my time is up. Thank you,
Okay.
Chair. I appreciate you.
Okay, and Dr. Davila, you want 30 seconds to respond?
if I may.
Go ahead.
right? Again, I will emphasize that, yes, the application that we
Point
put
of
forward as
order,
Toronto
Chair.
Public Health.
Point of order?
Dr. Ellis, on a point of order.
Yeah, thank you very much, Chair. And I guess, the time, as we know in this committee, you've been very generous in doling out the time in terms of allowing responses. I think the fact of the matter is, though, Chair, is I didn't ask a question. There was a very clear statement that, again, is very important to put forward, considering the fact that Dr. Davila wants to bring forward whatever her opinion is. When the question's asked, people, yes, of course, have time to respond. I didn't ask Dr. Davila a question, and I would say to you, Chair, that giving her a chance to voice her opinion, as she's done 3 or 4 times already, is not in the convention of what we do here. It's well beyond time.
And you spoke right through the time that was allotted, and there's some latitude in the chair, and quite frankly, I think that it's in the interest of the committee to afford that courtesy to the witness. It was a pretty damning monologue. She wants 30 seconds to respond. I'm going to extend that courtesy. Go ahead.
So through you, Mr. Chair, I just want to remind the committee that my role as a public health physician is to actually offer the best evidence-informed advice. So that's what I put in front of certainly local decision makers in Toronto, and that's what I would offer to Canadians, although my purview is obviously for Toronto. This is evidence-informed interventions. I cannot state enough. One, the application we put in front of the federal government was for a decriminalization approach, which is different from legalization, and it further argues for the necessity for more services across the board, including prevention, including harm reduction, and including treatment.
Thank you, Dr. Davila.
Chair, I guess a point of order, but I would suggest that Dr. Davila table the evidence on safe supply and decriminalization that she has with the committee.
We're going to go next to, and it isn't a point of order, and you're open to make that request. Any member is open to make that request. She's also open to provide any additional information she wishes. Dr. Hanley, please, for 5 minutes.
Thank you to all three of you for being here, particularly Ms. Krupp for your courage in being here, and also I add my condolences for not only your loss but your current nightmare of trying to help your son, who himself wants and needs help. Professor Fallu, maybe if I can start with you, I wasn't aware of that quote that Dr. Ellis made. But I thought it was an interesting one. What concerns you about a large C conservative approach to drug use?
Thank you for the question, because I think it's important to explain, because Twitter or X doesn't allow to say a lot of things. The reason why I said this was after Mr. Pierre Poilievre made a couple of public statements on harm reduction, drug policy, and the drug crisis we're facing. And quite frankly, there was a lot of half-truths and even lies. And I thought, if we want to have a democracy, and we want to have a democracy that works, we need to have an informed, fact-based debate, not some, emotional and half-truth arguments. That's why I mentioned that. And when I think of, not necessarily, I don't want to personalize, but any policies that's trying to push further and go in the path of prohibition, of repression, of stigmatizing language and policies for people who are human beings that are existing and have fundamental human rights, and any policies in that direction that are pursuing what we did for decades and put us where we are really bad and unfounded drug policy.
Thank you, and it's interesting that now you're currently in Lisbon. Anyway, we have talked about the Portugal model frequently in this committee study. Do you think the differing policy in Portugal is protective at all against the incursion of fentanyl into Europe, into Portugal in particular, or what are your observations there?
Really good question again. You have to mention that Portugal model has been evaluated. There's, as in any political evaluation, scientific evaluation, there's limitations. So it's difficult to isolate causes and effects. But we have scientifically a consensus that the model here has more benefits than the reverse. but we have to say that the model is still a punishing model, and it's not really, now it's better, but it's not reaching all drug users and heavy drug users. It mainly reaches cannabis users in big cities, so it's not perfect. It's really complex to have policies that work. We need to try something, but Portugal did, and it's no catastrophe, and it seems to be a step in the right direction.
Thank you for that. Dr. Davila, in the remaining minute of time, I wish I had more time for all of the witnesses, but can you maybe tell me your thoughts on the current political climate, especially within Ontario, where there are now the impending closures of safe consumption sites? But how is the current political climate helping or hurting the pursuit of what you describe as a nuanced approach to a highly complex crisis?
Well, through the chair, I'm not a politician. I am a physician trying to provide the best possible advice. I do find that when the conversation turns to the political, it becomes emotionally charged and takes us away from an evidence-informed discussion, which is incredibly important when we're dealing with this health issue. What I can say when we think about, supervised consumption services, which is one of the services that has come under recent attack and recent criticism, when we look at the evidence that's available in Toronto, we actually saw that with the implementation of supervised consumption services, we saw a 67% decrease in fatal overdoses within 500 meters of supervised consumption services. We see that there is an impact. So these are the kinds of data that need to come forward. There's no question. There's pain and there are challenges. Ms. Krupp spoke of her own personal experiences, and those are really very real. As I mentioned at the beginning, we're talking about people here. So all the more reason for us to really focus on the evidence, to think about the facts, to really engage in that very difficult discussion, because oversimplifying and suggesting that one method is good and another is bad and there's no gray or in between, I think is doing us all a disservice.
Thank you. Monsieur Thériault, 2 minutes et demie, s'il vous plaît.
Oui, merci, Monsieur le Président.
Mr. Thériault for 2.5 minutes. Thank you, Mr. Chair. The toxic drug crisis is a complex one. It is multifaceted, and it requires a lot of rigor to find solutions. We need to base our actions on facts. It's toxic to play political games and base ourselves on people's suffering. I would like to say to Professor Fallu that the Bloc questioned the leader of the official opposition and asked him what the difference was between legalization, decriminalization, and diversion. And he said that it's all the same. In a context like yours, in an international setting, such an answer wouldn't be very credible, but rising in the House of Commons during QP and saying that legalization, decriminalization, and diversion are all the same thing, while talking about cohabitation issues in Montreal, while exacerbating the polarization of a debate, stating you want to legalize. That's toxic in a debate. Do you agree with me? I agree that everything that is not based on facts is indeed toxic. There are experts throughout the world who examine drug policies. There are different policies, decriminalization, diversion, legalization. There are many different models. They're not all the same, not at all. There are models like decriminalization that would not solve an issue. For example, is Portugal safe against fentanyl? No. And we talk about diversion, dejudicializing. There are drugs that are in the streets, but anyway, we need to have a debate based on facts. There are people who spend their lives studying these phenomena with different political backgrounds. We're not all in agreement. Some believe that decriminalization is enough. I do not think so, because it does not solve the fundamental issue of these overdose crises and the control of products and stigmatization and corruption and violence. But I just want to say that nobody's talking about giving drugs freely to children when we're talking about legalization. Thank you, Dr. Fallu. Mr. Johns, 2.5 minutes.
Dr. Davila, the Conservative Doug Ford Ontario provincial government recently announced plans to close certain supervised consumption sites and prevent new sites from opening. This flies in the face in what we heard in earlier testimony from the Deputy Commissioner of the RCMP and the President of the BC Chiefs of Police from my home province, who both said we need more safe consumption sites, not less. Can you please share your thoughts about the potential impact of these closures on people who use drugs in Toronto and on public safety? And for example, do you believe that closures could lead to increased deaths and or public drug use?
Yes, so through the chair, very briefly, I do believe that there is real danger associated with eliminating supervised consumption services. As I've mentioned in an earlier answer, we see that supervised consumption services have actually prevented fatal overdoses. They also happen to be a method by which people are able to connect to important social services, and they serve as pathways to treatment. So I think the loss of supervised consumption services will mean the loss of those pathways, whether it's to improved social service or to treatment services. I think as well, when we look at what this means, we are seeing thousands of people across supervised consumption service sites making use of those services in Toronto. If those services are no longer available, I think what that means is that you'll have more and more people, particularly in the face of an affordable housing crisis, more people actually using in public and creating the kinds of challenges that we've heard many people around this table speak of. To say nothing of the fact that you will have more overdoses happening in the public realm, and that will be a draw on paramedics' resources, I would say on law enforcement resources, on emergency room visits. So there are some real challenges that I foresee associated with this, given our experience of supervised consumption services. But as I've said already to this committee and to all other parties who ask me about this, you need multiple points of intervention. We need multiple approaches. We need absolutely more prevention. Yes, we need harm reduction, and yes, we need treatment, and we need a better policy environment that actually supports people towards better health, whether they use drugs or they don't.
Thank you, Dr. Davila. Thank you, Mr. Johns. Next, Ms. Goodridge, please, for 5 minutes.
Thank you, Mr. Chair. So, Dr. Davila, as part of the application that you guys put in to make it legal for people to possess a number of different drugs, including crack, heroin, meth, you didn't have an age delimitation, so children could legally carry and use drugs as part of the model you put forward. Do you think it is responsible to have a program for children to have a legal method of using drugs?
So
in a recreational model.
Through the chair, the application that was put forward by us at Toronto Public Health was for decriminalization, which, as we've heard, is different from legalization. I do want to make the distinction, and I've said already to this committee, and I will say it again, the notion is not to promote or encourage widespread unregulated drug use. It's to recognize that drug use is happening and it is actually causing harm to people in our community, including those who are young.
Okay.
And so the notion is to try and reduce the stigmatization associated with that.
I appreciate this. We have very limited time. So in British Columbia, they developed guidelines to allow fentanyl to be prescribed in a recreational model to children under 18. Do you support that?
So through the chair, again, I'm not familiar with the model in BC, so it's difficult for me to comment on that.
Then do you support so-called safe supply being prescribed to children under 18, yes or no?
So through the chair, what I support is an assessment of individual patients or people who are under care and using evidence-informed treatment to support that.
So if
I
the
cannot
evidence
speak towards any specific situation without actually conducting a proper assessment.
Okay, would you want your children to be prescribed highly potent opioids if they were under 18 without you being aware of that?
So through the chair, I would want the medical system to provide appropriate care to my children for what situation they have in front of them. Clearly, as parents, we want to be involved in the care. I get that. And we have particular legislation in respect of consent to treatment. I think that's important as well. But to my mind, what we need to do is create an environment that actually allows for good medical care to be provided to individuals regardless of their age. And we need all
regardless
the
of their
approaches to
age.
be available.
So you want, regardless of their age, so you believe that children under 18 should be allowed to be given recreational fentanyl, hydromorphone, without their parents' consent, without their parents' consideration, because that's just a good idea?
So through the chair, that is not what I said. What I said is we have existing consent to treatment legislation. So I think we need to observe the laws of the country.
Fair enough. My last piece, I'm just going to go on a little rant here to Dr. Fallu. I appreciate that you are a tenured professor, and so you get to basically say whatever you want because that is your right as a tenured professor. One in 5 Canadians struggle with addiction. That means 4 out of 5 can use substances and perhaps don't fall into the ugly struggle of addiction, but 1 in 5 do not have that luxury. 1 in 5 try a substance and they can't stop. And I think it is highly irresponsible for you to be in a position of leadership, to be bragging to your students about how drugs have made you a better person. I don't think that sends the right message to students. I don't think that sends the right message to Canadians. I don't think that is appropriate in any way, shape, or form. And so I would just urge you to understand that addiction is a real, serious issue. And for the 1 in 5 Canadians that struggle with addiction, they do not have the luxury to experiment with drugs. They don't have the luxury to walk into a liquor store because they understand that one drink they pick up might be the last time that they go home to their family. So frankly, sir, we have an epidemic of addiction in universities, and students in those places require support and assistance, and I would urge you to consider your words.
Thank you for this explaining on what addiction is. Let me explain that stigmatizing people and creating misery with neoliberal economic policies are both core factors of why 1 out of 5 Canadian is addicted. And the fact is, any approach we might have in terms of criminalization, people are having addiction, and it's a human behavior will not disappear, and we have to do what science and living experience tells us it's best to help people and reduce this problem.
Thank you, Dr.
And this is
Fallu.
not by stigmatizing and criminalizing them.
Thank you. The last round of questions are going to come from Madame Briere for 5 minutes.
Thank you, Mr. Chair. And for the record, we just wasted almost 5 minutes of our time on a refuse request. Dr. De Villa, if my understanding is right, provinces decide of the training of physicians, what they can prescribe and when, what is getting reimbursed and oversee professional board conducting inquiries on bad prescribing. Is it accurate to say provinces have a role to play here?
So through the chair, yes, when it comes to the regulation of healthcare professionals, clearly they have a role.
Can you expand a bit on that?
So through the chair, there are regulatory bodies for healthcare professionals. I'm probably best positioned to speak to that is in place for physicians, because that's the one that I'm most familiar with. There's a training process for physicians to go through in order to acquire their medical license to practice. And there is an ongoing through the College of Physicians and Surgeons for the various provinces, expectations that you are meant to uphold in the practice of medicine. As well, for those of us who are specialist physicians, we have obligations to our college, the Royal College of Physicians, and in the case of family medicine practitioners, it's the College of Family Physicians of Canada.
Thank you. Dr. Fallu, tout au long là, du comité, on a entendu...
Dr. Fallu, we've heard comments throughout this meeting in favor of a more global approach that includes prevention. What do you think of forced treatment? Is it a little too soon to talk about forced treatment when we're already lacking in spaces for voluntary treatment? Absolutely. I said it earlier. We need to start by giving access to treatment. It is not very accessible right now. It is very highly stigmatized. Before we force people, there are many things that need to be done. It should be a last resort. And I'm being personally attacked here, and so if we're not talking about health, mental health, sexual health, as long as we're not talking about those issues and how they have an impact on drug use, without conversations on health, we will be making the situation worse. And that's why we're trying to see this as a public health issue and not a legal issue.
Est-ce que vous pouvez commenter?
Can you comment on that, please? Certainly. Apologies. That's why we're trying to state that it is a matter of public health. And for people who use alcohol and other drugs, it's not an issue for most people. Most people who use psychoactive substances are not criminals, they're not sick. It's a normal behavior, and that's why I wanted to come talk about it, to show that representations are currently being distorted. There are a lot of people in our society who are integrated into the system and who use substances. It is unfortunately the most vulnerable. And with prohibition, the application is discriminatory, and so it is the people who are the most vulnerable, who are in the streets, that are going to be the most impacted by prohibition. Thank you.
Thank you, Madame Briere. That concludes our rounds of questions. Colleagues, just a reminder that we have an informal meeting right after question period 3:30 until 4:25 with a delegation from the United States House of Representatives. It is an informal meeting, but it would be a bad luck if nobody showed up, so if you can make it, it would be great to have you here. We do have a hard stop at 4:25 because they're off to meet the Agriculture Committee, I think, after us. To all of our witnesses, thank you so much for being with us today. Ms. Krupp, please allow me to add my condolences for the passing of your daughter and my empathy for the challenges that you're going through with your son. it's no parent wants to go through that, and for you to be going through that and to have the courage to speak to it publicly, thank you. And thank you to our expert witnesses as well. Is it the will of the committee to adjourn the meeting? We're adjourned.
Thank you.